to introduce Chris, because I think everyone knows Chris Shaffrey, but he attended Citadel and then went on to University of Virginia Medical School, which became a recurring theme in his career. But I think, Chris, even in medical school, you were a spine guy, as I recall. I think we bumped into each other on the interview trail and you were talking about spine stuff. And he then completed orthopedic and neurosurgery residency at UVA and, pardon me, fellowships and residencies. And then had a stint in Detroit, followed by the University of Washington, Seattle, but then back to University of Virginia, as probably all of you know. And then in 2018, decided to move to Duke, where he's really the division chairman of Department of Orthopedic and Neurological Surgery in a tenured position. And as all of you know, he was just the AANS president, given many lectures all over the world, been heavily involved in the board and some very critical maneuvers in the board of neurosurgery to help us. And we're really, really pleased you could take the time to do this. And we were just talking earlier because the topic is really applies to more than just spine surgery, but it's an assessment, risk assessment, and who should be operated on and when should you not operate. So, Chris, it's really great of you to be here. And with no further ado, I'll let you get started here.
Thank you, Chris, for that really very kind introduction. These are my disclosures, but really for this particular talk, none of them are particularly relevant for what we're discussing. And one of the things that, as neurosurgeons, or if there are any orthopedic spine surgeons on here, what we do is really complex, and we treat very difficult conditions, and we have to be very skilled in what we do to try to get an optimal outcome. And what happens is that there is a real push because our conditions are so complex, and the historical outcomes have been not great, that there's a constant push to utilize advanced technology. Things like mortality, functional outcome depend upon decision making and technical skill. And because of this, there are pretty substantial variations in care. So if you have a phenomenal vascular surgeon like Dr. Ogilvy, you may try to do something in one way, and if you're in a community practice, you may try to do something else depending upon what the local skill is. And most of this is costly, and there is an opportunity for improvement in standardization of some of the things that we are doing. Now, if you're a health economist, you look at things where there's things that are done widely differently through different areas of the country or different areas of the world, and people say, hey, look, at something weird is going on here. Why is it that in some places in the country that somebody with adult deformity is treated on very regularly with surgery? In other areas of the country, it's never done. That's an area where there are questions raised. And what happens is, even within something like adult spinal deformity, there's stratification by how symptomatic it is. One person will have a different set of criteria for operative care versus the other. What radiographic parameters are used? Are people using regularly the same radiographic parameters? What level of comorbidity will you allow someone to have and still proceed with surgery? And what the patient's expectations and goals are. And if we get them out of the hospital and they're not in a nursing home, is that good enough, or do we really have to get people functional, functional as they were in their 20s to have an ideal outcome? So one of the things that I was really lucky in doing is, early in my career, I was encouraged to go and be very proactive as far as looking at the outcomes of the patients that I was involved in treating. And at least for adult spinal deformity, originally there were a couple big centers in the United States, and that was Minnesota and WashU, which had the vast majority of the publications and most of the things regarding new techniques and how to improve care came from those institutions. And when I was kind of an early to mid-career person, I had the opportunity to be involved in some multi-center study group activity where there was a commitment from the people within these study groups to improve care, and in this case for adult spinal deformity. And what's happening is these study groups, and particularly the one that I was involved most recently and for the last 15 years, has been something called the International Spine Study Group. And with this International Spine Study Group, we're up to almost 400 publications from the group. And these publications and whatnot have really resulted in a change in how we have cared for patients. And one of the things that has come from this is a realization that a specific minor technique, what you have as far as screw density, whether you use a T-lift or an A-lift, where specifically you put an osteotomy, has a far lower impact on what someone's eventual outcome than some physiological factors are. And this discussion is not just theoretical. So this is a publication that came out in Journal of Neurosurgery Spine in October. And this is a combined data set for the ISSG, the International Spine Study Group, and the European Spine Study Group, which is a European focus group that use the same metrics as the ISSG. And what we looked at is over 1,500 surgeries that occurred between 2010 and 2016 at 23 international centers in 5 countries. And this is the actual paper. And this is what we have found, that between 2010 and 2016, our major and minor complication rates have diminished over 50% during that time period. And similarly, our outcome, whether using ODI or SRS-22R, has improved by almost 50%. And in 2010, there were 11 directly attributable mortalities, and in 2016 there were 0. And so what's happening is, by our peer group disseminating information and looking at things, we are treating people better. There's a follow-on paper coming between 2016 and 2021, and we're waiting for the 2-year follow-up for that. But this has shown an additional similar incremental improvement in reduction of complications and improvement in outcomes. We're treating far sicker patients. We are doing more aggressive treatments. We are getting better outcomes, but have really markedly diminished our rate of complications. And these are some different papers that have come out about the use of predictive analytics and other things that are showing, and these are all in the last month or two that have come out, that is going to make this more digestible, that if people can have a risk calculator that they can go and look on their smartphone and put in patient data, or have a direct download for electronic medical record like Epic, this will allow people to be able to sit down in real time and have a conversation with the patients about what their expected outcome and what their expected complication rates are for surgery. Now, what happens is that there was a historical belief that people with adult deformity, if they kind of took it easy and didn't do very much, as far as activity, they kind of spent their time on their porch, and that they didn't overdo it too much, that they would be fine with their condition. And the fact is that adult spinal deformity is perhaps the most debilitating condition that we treat as physicians. And this was a study that was done looking at the health impact of symptomatic adults with adult spinal deformity. And what it did is it was found that patients' age and the severity of the deformity, particularly in the sagittal plane, really impacted the level of symptoms. So one of the things which has been done, and there's been some historical work that was done out of Iowa, looking at adolescents who did not have their thoracic scoliosis treated. And what was shown and what's been correlated by the work that we've done, as a young adult with a relatively mild thoracic scoliosis, it has absolutely no impact on health status. But as people become older and people develop particularly degenerative scoliosis in the lumbar spine with a loss of alignment, they have a much greater impact on functioning. And this middle portion of the slide shows a 63-year-old who has significant loss of lumbar lordosis, pathological loss of lumbar lordosis, and her disease functioning correlates to somebody having an above the knee amputation. And in the most extreme example on the right, this is a 78-year-old male who has sagittal imbalance, coronal imbalance, other problems. And his disease functioning correlation is somebody who is blind, a bilateral above the knee amputation, who has heart and lung failure. And with this type of profound impact on health, this is why people are so desperate when they come to a clinic to say, look at, something has to be done. My brother, sister, mother, father can't continue to function. They are in horrific pain. And particularly, as we, move away from opiates and whatnot, it puts people in a difficult situation. Fortunately, again, as neurosurgeons, there are some things and some new and better technologies, particularly in functional neurosurgery, where things like spinal cord stimulators and other things can at times provide some relief. But some of this is people are desperate for some method of treatment for their care. Now, this is a patient that I operated on about 6 months ago, and this just shows you that we have good technology now. This is a lady with pretty substantial scoliosis, very debilitated due to her symptoms. And one of her biggest problems was her rib cage impinging upon her pelvis, and because she had her abdominal cavity so constricted, she had early satiety and had nausea, vomiting, really couldn't eat, and was abjectly miserable. And basically, this is the operation that I did. This is a kind of soon after surgery film showing the type of correction that we can get with things. And the fact is that as far as our techniques are concerned, we are somewhat plateauing. And I think there are some new things in minimally invasive surgery and whatnot that, again, that can reduce morbidity. But we have a pretty good array of tools in our hands to improve people if physiologically, they are able to be improved. Now, what's happening is that it is clear that for some young adults with severe pain and deformity, that surgery has been beneficial, and we've had relatively little pushback. I was involved in an NIH-funded study for adult symptomatic lumbar scoliosis. And, I think everybody agrees that for young people, surgery works well. And this is a study that just came out this past week, looking at our assessment of people with return to work as far as life productivity and different factors. And it's shown that surgery does a really, really good job. The problem is that we're facing this a belief that as we start to treat people who are older, that our complication rates and in some cases our outcomes are poor enough that it's just not worth it. And so this is some work from Rick Deo out of University of Washington. And basically, his complaint, and this was a JAMA article from about 10 years ago, that said that there was this worrisome increase in complex fusion procedures, and they had increased 15-fold. And what happened was, with these complex procedures increasing, the number of complications, including severe complications, was increasing as well. And I think that this is, both of these statements are clearly true, but it doesn't color the fact that, again, that people are very, very desperate due to a condition that, again, is severely debilitating. And if you had somebody with vascular disease that was going to, likely have both of their legs amputated, there would be, there probably wouldn't be the same degree of pushback as there is with spine surgery. Now, what happens is, and I think that, through the ISSG and other areas, we've tried to be pretty responsible to say, hey, look can we better define what the absolute complication rates are? What is the impact of the complication rates? And again, back to the sort of the title of the talk, is there a thing where we should be saying no to people? Say, look, this just isn't responsible to do. Now, what's happening is you're going to see there's sort of a mixed picture. And what happens with this mixed picture is that you're looking here, and this is looking at almost 350 patients with adult deformity, and there was a very high complication rate in this group of people, and a number of people required revision surgery, which makes it quite costly. And it was found that patients who were older had a higher BMI, had an increased number of comorbidities, who had previous spinal surgery, and those who required a 3-column osteotomy to correct their deformity all had greater complications. And this shows you, I mean, it's a sobering list of complications that occurred in this group of patients. Now, what's happening is this is looking again at patients who required 3-column osteotomies. And this again showed that almost you're nearing 100% complication rate in people that need major realignment to correct their adult spinal deformity. And this just shows from that 3-column group, there's one poor individual that had 9 major complications associated with the surgery. And again, this is very sobering. This is some work. This is the Scully risk study that Larry Lanky, Michael Failings, and I did. And this is to look at the true incidence of neurological deficits associated with major deformity surgery. And what we found is that almost a quarter of the people had some weakness after surgery when we did a detailed independent neurologic exam in each patient. And again, it was found that if you had a neurological deficit, your outcomes and your recovery in general weren't as good. So this gets back to sort of a typical patient that I see. This is an 82-year-old woman who, through her life, has been in good general health and has lived independently. And as recently as a year ago, walked up to 2 miles, but she cannot make it out to her mailbox. And basically, her children bring her in and say, look, if you can't make her better, she needs to go to a nursing home. She cannot live the way she is. We find her, or the neighbors find her, sitting down in the middle of the lawn, of her lawn, because her back hurt her so much that she ended up on the ground. And she has hypertension and GERD. Her ODI is 61. And this is her CT myelogram, and it shows some a history of some vertebral compression fractures, and it shows that she has very severe spinal stenosis. You can see advanced disc degeneration. And so this is the thing, is that she comes, and again, as we've shown, and similar to the gentleman who had the functional disability equivalent to the amputations and blind and heart and lung failure, they bring this patient in, and you try some different non-operative treatments, either injections or whatnot. And while I'm doing this, as you're going to see in a minute, we start the surgical optimization process to reduce frailty. And what happens is whether we can get them healthy enough ultimately determines whether we can operate. So the question is, should this patient be a candidate for surgery? And there's a spectrum of society who just says no. We should just, this person will be better to go to a nursing home. The problem is, even some of our end of life care people are reluctant to adequately treat that type of pain with narcotics. If we do surgery, are there strategies to reduce the complications? And is there a predicted complication threshold that we really shouldn't exceed? And as I said, that's the completion of the talk. So this is a really important paper. And this was by my former partner, Justin Smith. And we looked at a group called the Spine Deformity Study Group. And we looked at a little over 200 patients, and we divided patients into, kind of younger, which was 25 to 45, kind of middle-aged, 45 to 64, and those older than 65. And what, as we would expect, that the elderly patients had greater disability, worse health status, more severe back and leg pain, and were much more debilitated. And these different groups had distinctly different complication rates, with the complication rates in the elderly patients being far higher. But despite that, okay, you can see the marked difference in major and minor complications. So 71% of people had a significant complication. But the fact is that 2 years, the results of surgery were all the same. That people were all, had an ODI in the low 20s. And what's happening is the elderly patients who were the most debilitated perceived, and it was demonstrated to have the most benefit, despite the fact that they had far higher complication rates. So at 2 years, these people are very happy. They're very functional. Now, they may have gone through hell to get to that point at 2 years. But the fact is that these people are doing really, really well. And we have a paper that just got accepted by Lancet, that has shown that these people, after you fix them, their overall health status is actually better. It allows them, their blood sugar control is better, their blood pressure control is better. All of the different physiological parameters that we're using to assess health now have improved despite the major surgery, because they are able to be far more functional. This is the results overall from the Scully wrist trial, which I mentioned, looking at neurological function. But what we found was that these patients also did extraordinarily well out to 5 years after surgery, even the ones who had a neurological deficit. So basically, I did this operation again. This patient's now about 10 years old, and I'm still seeing her. She's in her 90s now. And she had a 5-hour surgery. She had 1,300 cc blood loss. She was in the hospital for 14 days, including 4 in the ICU. Her post-operative care, she was, again, one of these people with numerous complications. She had delirium, she had ileus, she had a DVT, she had atrial fibrillation, she had urinary retention. She went and did a 28-day rehab stay, and her family just said, look, we want her in assisted living. So she is in assisted living, but her ODI is at 22, and she is very happy. And the question is this a success? Should this have been done? Are the complications expected or unexpected? And is there a way that we can bend things to get even a better outcome? So one of the things which I think is really, really important, as you're going to see from here on out, is assessment of frailty is important. And us bending the frailty curve is going to have a profound effect on how patients end up doing with these major surgeries. And what happens is frailty is really the functional capacity to bounce back from a major insult. And there's a variety of different factors that we have found that impact frailty, how much you can go and bounce back. Now, we're not the only, part of medicine that is looking at frailty. This was a study looking for major abdominal surgery. And what they found is by using a multidimensional frailty score to assess geriatric patients, they were able to much more accurately determine what their capability and what the resiliency was to be able to undergo these surgeries. And one of the things is a lot of people use the Charlson comorbidity index as an assessment of frailty, but actually there are a lot of factors that are probably better. And you're going to see, this is what this study done, and you're going to see a little bit further along of what we're actually doing currently to assess frailty and to assess improvement in frailty with surgery. So these are the factors that they used for the study. And what they found was they used several different instruments to be able to go into to assess that. And what they found was their ability to predict mortality, discharge to a nursing home, and major postoperative complications very, very closely correlated with their frailty assessment. And, and so for me, and what I'm trying to do is, you can see these are two 79-year-old ladies, okay? And which one of them do you think is more likely to be able to tolerate a major spine surgery? The lady on the left or the lady on the right? And what we're trying to do is try to move people towards being more robust and reduce their frailty. So what we had done through the ISSG was looked at a variety of different models to go and to calculate whether, how frail someone was before surgery. And in our first iteration of this, 4 or 5 years ago, we started off just saying we're going to divide people into 3 categories: those that are not frail, those that are frail, and those that are severely frail. And what's happening is, it's been shown that the greater, if you move from non-frail to frail and frail to severely frail, there was a close correlation with risk of major complications, problems like proximal junctional kyphosis, failure of healing, deep wound infection, longer hospital stay, etc. And these are some of the factors that we used in our frailty assessment model. And this just goes and shows the complication type when we compared non-frail to frail and severely frail to non-frail. And one of the things that we also looked at was, are these frail and are these severely frail people, are we getting enough benefit from their surgery? And there was some belief that we should just cut the line at the difference between non-frail and frail, and just say we should just say no to everybody who is either frail or severely frail. And unless that we can get them into the non-frail category, we just shouldn't be wasting our time. But when we looked at the data, what we found was it was the frail group that actually had by far the greatest level of improvement with adult deformity surgery. Now, those that are severely frail, they just didn't tolerate the surgery. But if you were frail, okay, you were likely to meet substantial clinical benefit for almost every factor that we used. And these are people that made enormous improvement in their overall functional status as far as their pain control. And some work from this is what we submitted to Lancet that went and showed that these people ended up returning after their major surgeries, and from a general health perspective, almost back or back to being, back to sort of age appropriate levels of health. So this really kind of opened our eyes and said, geez, instead of having a gradation point between non-frail and frail, is there a way for us to get these severely frail patients improved enough so that they are in the frail category, so that they can have a similar degree of improvement? So the question is, can we alter frailty? Is this? So this is what I do, and you're going to see it sort of in a computer spreadsheet form. But on every one of my patients, when they come in and we're doing any consideration of surgery, we look at their blood sugar, we look at their bone quality, we look at their body mass index, we look at cardiac factors, we do a routine infection screening, we do mental health screening, and we also do an assessment of their amount of social support. We check their nutritional status. We assess their morphine milligram equivalents and adjust that. We go and find, in most cases, at least in North Carolina, they haven't done an aggressive prehabilitation program. If they're smokers, we insist on smoking cessation. And basically, as you're going to see at the very end, we have now standardized this into a predictive analytics assessment of their potential outcome and complications, where we can go and say, hey, look at your bone density is this, or your other factor, your nutritional status is this. And by sliding something on the model, we can show what impact that is going to have on their eventual outcomes. And this is actually how we do it. These are the different, we have something called the PASS clinic now at Duke that has been set up, that goes and routinely puts all of those factors in together. And we basically see what they are, and we see if they're essentially non-frail, frail, or severely frail. And in essence, what we're trying to do is always upgrade the patients that we are seeing. Now, some of the stuff is relatively simple, and you don't have to do something quite as sophisticated as we are, but there are some factors that are really have been shown to have major impact, particularly on bigger spine surgeries. And one of those is the hemoglobin A1C. So many of our patients have become deconditioned and obese and have type 2 diabetes. And it's been shown that those people with a hemoglobin A1C of less than 7 have a substantially reduced risk of wound infection and wound complications. So our goal is, and we are aggressively treating patients who are diabetic, to get their hemoglobin H1Cs less than 7. And in fact, with rare exception, we will not operate on somebody for at least an elective spine reconstruction unless that has been accomplished. A second factor is nutritional status. And what's happening is that, again, because these people are debilitated, in some cases don't eat well and whatnot, they can go and be nutritionally depleted. And this is something that has been really sort of under-recognized and underestimated. And what we use is a general term. We have some more sophisticated labs looking at lymphocytes and prealbumin and albumin, but generally an albumin of less than 3.5 grams per deciliter is recognized as being malnourished. And this study out of Duke looked at a spectrum of patients undergoing surgery, and they found that over a third of patients undergoing surgery were malnourished by this criteria. And some other papers that I removed show that, again, the really serious impact on complications, fusion rates, and other things with this. And so what they found as a follow-on to this is that of the people that were operated on, more than half of them would have been considered obese. And people say, how can somebody be obese and also be malnourished. And part of it is this thing. This is a YouTube guy, and this is a guy that decided to go, and for 120 days, his only source of sustenance was making this stuff which he called holy water, which was a bag of Doritos and a half gallon of Mountain Dew that he put in a blender and drank this breakfast, lunch, and dinner for 120 days. He absolutely, totally ruined his health by doing this for 120 days. And I'll tell you, there's a lot of people that in North Carolina, at least, come to our clinics with a big bag of Doritos and a big bottle of Mountain Dew, who probably, isn't conscientiously doing this, but practically has a diet very similar to this guy. And this guy, as I said, he in 120 days ruined, he started off, I think he was a little chubby to begin with. Nobody would ever, think about doing something like this. But basically, he did this for 120 days, and he had significant type 2 diabetes, and his cholesterol, every single measure just completely went through the roof. And that's how you can have both of them. Now, one of the things, and if there's probably one single point to take home from my talk, is probably this one. And it's been shown that preoperative supervised exercise improves outcomes and reduces complications for major surgery. This was a study looking at elective abdominal aortic aneurysm repair. Physiologically, it is probably the closest operation to a major deformity reconstruction in the elderly. And what they did is they randomized people into 6 weeks of preoperative supervised exercise or just standard treatment where they didn't. And what they found was that they reduced complication rates by 50%. They reduced hospital stay by 50%. They reduced mortality by like 60%. And it was just an enormous impact on how people did this. This is another study looking at, again, a personalized rehabilitation program. And again, the complication rates were reduced by 51% by doing this. And we are part of a couple now prehabilitation studies looking at the outcomes on smaller spine surgeries. But I'm going to tell you, the preliminary data shows that prehabilitation is something that makes an enormous impact. So for me, at least, every one of my patients, just like the smoking cessation, just like the reduction of the BMI to less than 35, just like the hemoglobin H1C under 7, and our nutritional status with an albumin greater than 3.5. This is an absolute. If you do not do, and what I do is I do aquatics-based physical therapy, and they have to come in with 28 signed PT sheets, or I will not operate on them. And it's really been absolutely amazing. Now, one of the things which takes a lot longer lead up to doing is effective treatment and improvement in bone health. And this is, again, for the people that we're operating on that conditions such as proximal junctional kyphosis, and other things are very directly correlated with osteoporosis. These are things that how the screws fix into the bone, how the fusion takes, all of these things have been shown. So some of the stuff is relatively easier. So one of the labs that we take is we check vitamin D levels on everybody. And it's been shown by getting vitamin D levels up to a normal status, it's been shown to go and to improve fusion rates and other issues. And again, the more debilitated the patient, the more likely they are to be vitamin D deficient. And this vitamin D levels has a direct correlation about non-union and time to fusion. One of the things that we have been doing is in those patients with true osteoporosis or those with more significant osteopenia, and we'll say these are people with a T-score of minus 2.1 or 2.2, we've been much more aggressively treating them with some of the different anabolic agents to increase bone density before we even operate on them. And we were, historically doing this with a teriparatide analog, but now there's some new drugs such as Timlos and Evenity that can also improve bone density. This just shows the effect of teriparatide. It improves insertional torque. It increases fusion rates. It's been shown to reduce the incidence of PJK, and improving bone density is one of the critical factors to reduce the complications with surgery. Now, what's happening is that there's a lot of data to gather together, and for the average person, and particularly for somebody out in the community trying to do it, and we have a sort of a big clinic setup to do optimization, but what we've tried to do is to go and to do predictive analytics modeling to allow us to be able to, as I said, dial in people's individual factors. And as you're going to see in a second, that for those places who have an electronic medical record that uses Epic, there's a capability to do something very similar outside of the ISSG model. But these are the different factors when we were looking at them that we felt that were predictive of complications and predictive of outcomes. And this is work from Chris Ames, and this actually goes and shows the preliminary modeling that he had somebody from Google help him put together for machine learning to try to go and to determine what factors were most important to go into this predictive analytics. And this is some work from Chris Ames talking about these different algorithms. And the fact is, with greater than 90% accuracy, depending upon the different factors used, we can predict when someone's going to have a complication, and or even moving to the point of those people at a much higher risk of having mortality. So we just recently wrote a paper looking at, when should we say no? And and what's happening is that there's certain factors that do impact things, but basically the criteria, the bottom line was that the criteria that we use for severe frailty, if you were severely frail and we cannot improve it, the risk of complications and the lack of a likelihood to improve significantly is probably the no go point. But there are some people that I have, through a combination of optimization, have moved them from severely frail into the frail category, and that they have done extraordinarily well with major surgery. Somehow I think that I reached I cut a few slides out of this, and I probably cut the end out. So basically the bottom line is that our techniques are good. And again, we can always refine things a little better. But these factors, improving the frailty of our patients, is having a far, far greater impact on outcomes right now than any minor change in technique. And as when Chris and I had spoken, I wanted to make sure that we had something. I think that anything where there's a fairly substantial physiological stress. And it could be, again, for some of these failed people with an unruptured aneurysm, or somebody who has, that needs a major, brain tumor resection, or other different factors that some of this stuff may be germane to the treatment of those patients as well. So thank you.
Chris, thanks very much. We can take comments, questions from people.
Yeah, this is Martina Stopler. Thank you so much for giving this talk. I mean, I think just your workup into frailties is very interesting and definitely something to take away. I have a couple of questions. You quoted, complication rates up to 30% in severe, 70% total, but that the patients fell in the older group. What is your loss to follow up? I mean, not everybody will probably make it to 2 years. Do you have any ideas how many people you lose to follow up, or many people succumb to their complications? And then after the question, I have another comment. Thank you.
So I combined several different studies here. So for the adult symptomatic scoliosis study, the one that was NIH funded, our follow-up rate was 94% at 2 years. And we're just doing our 10-year follow-up for that study, and we're still above 90%. We have a study in ISSG called CADS, Complex Adult Deformity. Our follow-up rate on that is 89%. So each of the different, so some of this stuff is that, for good or for bad, we're kind of slicing the apple in different directions. And that, and some people are annoyed by that they say, well, you had one thing where you had a follow-up rate of 92%, and you had something else where it's 88%. Sometimes when we look at something, there is potentially a higher portion of people dropping out. Now, one of the things which, that people get annoyed about is people say, oh, you make it so difficult for people to join the ISSG. And part of the reason why it's difficult is we always want to make sure that we are getting this level of follow-up. And to follow these people up, it takes, our clinical coordinators and whatnot really hound them to achieve the follow-up that we do. And it is not for the faint-hearted. Now, what happens is hopefully you have a good enough relationship with people that they want to come back and see you. But, there are people that just get old. And one of the things, and Justin Smith just wrote a paper, I don't know if it's come out yet, it's going to be in Journal of Bone and Joint Surgery. And for a lot of these people, why they don't come back or why they're more disabled is they've broken their hip, or they've, had a knee replacement that got infected, or they have had worsening of their congestive heart failure. So some of the stuff, it doesn't always mean that your back surgery has been a failure, but we for all of our studies, we shoot to have greater than 90% 2-year follow-up.
No, that is impressive. And I think that makes the results very valid that you have such a high follow-up. We started here, and I'm wondering, I mean, you have a great setup there with your clinic and your research staff, and our orthopedic surgeon here started to co-round with a geriatric internist. So I think that is they just decrease delirium, and I'm wondering if you're doing that the same, or if you thought about that.
We don't, but part of it is that we in general, I feel that a lot of this is proactive. That so much of this stuff that where you get into trouble is that you've had someone who has had difficult, that you haven't optimized them to the same degree. So yeah, do I still get somebody who has a little bit of delirium? The answer is yes, but it is far less than what it was 10 or 15 years ago, because we've got these people out exercising on a daily basis. We have different things going on. We've optimized their medications, and we're very thoughtful. We do have a kind of an ERAS protocol for the patients in the ICU. So we're doing things where people are much more likely to be on things like lidocaine rather than heavy duty narcotic pain medications, to try to go and to reduce some of these factors. And again, I've got probably another whole talk, but things like using mu inhibitors to reduce postoperative ileus. There's other things that we're doing to gradually try to bring these things down. So I think there's nothing wrong with rounding with a geriatrician, but I think that in general, unless it's sort of a more multidisciplinary thing, that you're working on, first of all, optimizing them beforehand, and then looking at factors that are generally not tolerated well. So, so some of the things that some of the people are doing is we're moving towards using kind of Exparel-based paraspinal blocks so that they have much less pain after surgery. There's other things that we're doing. And I think as a geriatrician, as part of that multidisciplinary effort, I think sounds reasonable. The question, which I feel, is that some of the other things are probably as likely as important.
Thank you.
Hi, Chris. It's Steve Papavasiliou. I wanted to
Steve.
really thank you so much for the presentation. And I think the biggest challenge we all have is when not to operate. And the work you've done in that area, I think, is extremely important. As you know, Justin Smith's paper is the latest group is 65 and older. I don't think anyone will hesitate operating on a 65 or older. We will think about the 82 you did. And I don't think there's enough done in that area to tell us when not to operate and when to operate. Can you comment on that?
Yeah, I think and again, one of the problems is, and one of the things which I've said to Chris is when you have to take, 40 different factors to calculate whether someone's, frail or severely frail, that makes it very difficult for the average person who's out in the community or is not using one of our predictive analytics calculators to say, okay, is this frail or severely frail? So, Chris is right now working with one of the device companies to have a digestible phone-based app where you hopefully can download the information. I took it out, which was a mistake. There's something called a Python calculator, and I don't know if you guys in the Harvard system use Epic, but the Python calculator is essentially can do the same thing. And a couple places have gone and contacted Duke about what they did to Epic to make this Python calculator. And it's used, again, for more than just spine. It's used for general surgery and whatnot, to be able to go and calculate what the true risks of major complications and poor outcomes are. And so what's going to happen is either through a commercial application or through your EMR, there's a lot of this coming online to be able to make that decision making. And so the thing that is frustrating with this is if you can go and get somebody better, okay, if you can make them, again, from severely frail to frail, okay, you can likely get a really good outcome even in these elderly patients. It's the severely frail ones that you just don't want to operate on. And that's, and again, these are somewhat difficult discussions because people are desperate. They see their family members really suffering with these conditions. And, and it's a little bit, it's like going to Las Vegas, whether you can get them through there, particularly if they're severely frail. So just as sort of the last slide that I had there, it really, this thing about severe frailty versus frail. If you can get them to be frail by the things that we're using, you can likely get an acceptable level of outcomes compared with the complications.
Is there an easier way to determine frailty?
Well, that's what we keep on trying to do. So what we're doing in our most recent set of studies, we're doing something called CADS-2. And in CADS-2, we're doing several different things, and we're doing sit to stand testing. We're doing hand dynamometer strength testing. We're doing skin fold testing, and we're also doing telomere length testing, okay, to see how long your telomeres are. And our hope is that we'll be able to go and with the telomere length, and we're not there yet, but our hope is with that is to say, hey, we send off a test that determines how long your telomeres are. And if they're too short, you're too frail, okay? And we're going to say no. So the answer is we're trying to do something simple that, you essentially send off a blood test. We also, as a fallback, are doing things like sit to stand testing, timed, walking tests, and other factors to see if we can functionally better determine who's frail and unfrail. And we're just at this year's SRS and IMAS meetings are having the first preliminary results for that, which looks like functional testing may be a good way to determine those that are non-frail, frail, and severely frail. So the answer is we're working on all those different things, and probably 2 or 3 years from now, I'll be able to give you a much more accurate and simpler way to assess it, rather than having 40 different factors put into a computer model.
Thank you.
Chris, I think this is fascinating. And I think spine, actually, I hadn't thought about it as much until this morning. You have a much more opportunity for the prehab than some of our other subspecialties. And it's fascinating, the number of things you're looking at. As it gets more granular, and as you get more data in the system for artificial intelligence and computer modeling, I mean, this all used to be just surgical judgment, right? Surgeons would look at a patient and assess their medical situation, comorbidities, as well as the particular surgical issue, and assess risk. So we're getting much more granular with these other factors. Is there a point where this becomes a PCP sitting in an office, puts in the numbers and factors and says, I'm not even going to send you to Chris Shaffrey because I'm telling you, you're not going to get surgery, or you're going there because you need surgery. In other words, the decision-making sort of is extracted.
Well, the problem, and the answer, Chris, is maybe. The problem is that a number of these factors are changeable, okay? And this is where, that if you went and put in and they have severe osteoporosis and they're severely debilitated and they're malnourished and they fail every functional test, there is a subgroup of those patients who will, by themselves or with their families' encouragement, will change their lives and become functional and whatnot. And the problem with it is very time and labor intensive to encourage people to get out of the rut and to change that. And I'm lucky because I have a number of people in my clinic that are engaged and work hard on doing that. But that's the problem. For a PCP, it might be plug the initial numbers in and you don't meet the criteria, and they're not really working to go do it. And that's, that we all see the number of people that are sent from their PCP that are still smoking, who are still obese, who are still deconditioned. And if the PCPs were so interested in doing this, And again, I mean, it is enormously net labor intensive, and they don't get really paid to do it. I don't really get paid to do it either, but we have grants and we have other different things that allow me to make this happen. But that's where the issue is, and that's, I think, the mistake of this being computerized, that you put the information in and you get it from your electronic medical record, and your PCP puts risk assessment and say, no, it's just too high, is that you don't realize that many of these factors are changeable.
Yeah, I think that's the big difference in your situation as opposed to some of the other situations. But it's certainly getting much more granular and refined. And I see our time is coming up here, but I just want to really thank you for taking the time to do this. It's generated a bunch of ideas, I think, and it's really interesting to hear about. And I just want to thank you for taking the time to do it.
Well, thank you, and I appreciate the opportunity. And as I said, for me to show some huge case of me doing something, that gee whiz thing, I think this is much more applicable for the average person to say, hey, look at, well, before I do my spine fusion, let's get that person's hemoglobin H1C to a better level. And it does, all this stuff does make a difference. And the initial slide really does show, we are doing things at least 50% better than we were doing them 5, 7, 10 years ago. So thank you all again, and you have a wonderful day today.
Thanks much.